Good afternoon, everyone. Welcome to this session on vulnerable populations in emergencies and disasters. Over the next hour, we'll delve into the crucial subject of risk, equity, and the necessity of inclusive emergency management. The core concept here is that a disaster's impact is rarely felt equally across a community. When a crisis strikes, whether it's a sudden wildfire or prolonged pandemic, it's a fundamental truth that disasters do not affect everyone equally. Certain demographic groups and individuals with specific needs face a disproportionately greater risk. This elevated risk manifests in several ways: injury and death. For instance, a person who relies on oxygen and a ventilator may face a life-threatening situation during a prolonged power outage, unlike a healthy, self-sufficient neighbor. Worsening chronic illness. The disruption of supply chains or evacuation routes can sever access to critical, time-sensitive treatments, potentially accelerating the progression of a chronic disease. Loss of essential support systems. A disaster can instantly isolate an older adult who relies on a daily home care nurse for essential support, leaving them without critical daily assistance. Our objective in this chapter is to provide a clear framework for identifying these vulnerabilities and, crucially, developing plans that address them head on. Fundamentally, a one-size-fits-all emergency plan fails those who need the most support. Imagine a mandated community-wide evacuation order. A family with 3 cars and no dependencies can execute that order instantly. But for a person who uses a specialized power-dependent mobility scooter, a standard instruction to go to the nearest shelter is simply inadequate and potentially dangerous. Inclusive emergency planning isn't just a matter of compliance. It's a commitment to justice. It ensures equity, that resources are allocated based on need, not just on a uniform distribution model. Accessibility, that all facilities, communication, and transportation are usable by everyone. Protection of functional needs, that the critical functions people perform daily are maintained even in a crisis. The ultimate goal is to ensure a safe, dignified response for everyone in the community. Public health plays a critical, often invisible role in crisis planning. It shifts the focus from simple survival to holistic well-being and equity. Public health professionals ensure advocacy for inclusive planning. They are often the voices insisting that the planning table includes representatives from vulnerable communities. Functional Needs Support Services, FNNS. This is the logistical framework for addressing the specific needs we discussed: mobility, communication, medical care, etc., during a response. Data collection and resource allocation. They track which community segments are most likely to be isolated or need specific support, allowing resources to be pre-staged effectively. Collaboration with community organizations. This involves working with, for example, disability advocacy groups or food banks who already possess the trust and contacts within at-risk populations. The unwavering focus is safety, dignity, and equitable access to all disaster services. We move past simple labels and instead define vulnerability by understanding functional needs. This provides a practical lens for planning. Vulnerability is categorized by the specific function that is at risk of disruption. Independence, the need for specialized equipment, such as power assist wheelchairs, CPAP machines, or home dialysis units. Communication, reliance on methods other than standard oral English, such as ASL, augmentative and alternative communication devices, or requiring an immediate interpreter. Transportation, the inability to self-evacuate using a standard vehicle or public transit, often due to physical mobility issues or being bedridden. Supervision, requiring daily assistance with activities of daily living, ADLs, or needing behavioral support for cognitive conditions. Medical, the need for ongoing clinical or technological support, such as wound care, IV infusions, or maintenance of a specialized feeding tube. While functional needs define why someone is at risk, it's also important to identify the common groups where these needs are prevalent. Examples of at-risk groups include older adults who may have multiple chronic conditions or limited mobility, very young children who rely entirely on adult supervision and specific supplies, people with disabilities across the spectrum, mobility, cognitive, sensory, people with chronic illnesses, such as severe asthma, diabetes requiring insulin, or cancer patients undergoing treatment. Non-English speakers who may miss critical life-saving alerts due to language barriers. Low-income households who often lack the financial cushion to stockpile supplies or evacuate great distances. Recent immigrants who may distrust government warnings or lack awareness of local emergency procedures. It is vital to remember that vulnerability is complex. It may be physical, social, economic, or communication related, and often these factors intersect. The expectation of inclusive planning is firmly rooted in federal law. These key laws have shaped how we must prepare. Rehabilitation Act, 1973, Section 504 ensures that any program or activity receiving federal funding, which includes most disaster response efforts, must be program accessible to people with disabilities. American Disabilities Act, 1990, this mandates equal access to all services, facilities, and public accommodations. In a disaster, this means that shelters, food distribution sites, and evacuation staging areas must be physically and communicatively accessible. Post-Katrina Reform Act, 2006. Following the recognition of catastrophic failures in supporting vulnerable populations during Hurricane Katrina, this act formally integrated functional needs into all Federal Emergency Management Agency, FEMA, planning and operations. Emergency planning must proactively ensure access for people with a wide range of impairments, specifically including vision loss, hearing impairment, mobility limitations, cognitive disabilities, and medical device dependency. This compliance obligation is comprehensive and must cover every phase of response. Communications. Are alerts available in Braille or ASL? Transportation. Are lift-equipped buses available for evacuation? Sheltering. Is the shelter floor plan ADA compliant? Evacuation. Are specific procedures in place for non-ambulatory individuals? Effective disaster planning requires a diverse team. An inclusive disaster planning council should go beyond the usual agencies to include government agencies, fire, police, public works, NGOs, Red Cross, faith-based groups, utility companies, community representatives. Crucially, this council must include people living with disabilities and their caregivers. Their lived expertise is invaluable. They're the only ones who can truly articulate the barriers they face and stress test the effectiveness of a plan. Without their input, plans will inevitably contain blind spots. The best plans are useless without trained personnel. Responders must receive specialized training that goes beyond basic first aid. They need to know the proper use and recharging of medical devices, understanding that turning off a ventilator requires a specific protocol. They must be proficient in safely handling oxygen tanks and lift systems, ensuring safe transfers and transport. They must be trained in the unique operations of functional needs shelters, which require more medical knowledge and staff-to-patient ratios than a general shelter. In parallel, community education is essential, empowering individuals to manage their own risk. Personalized go kits. These must include not just food and water, but specialized items like hearing aid batteries or catheter supplies. Medication management. Instruction on how to safely store, organize, and transport a 2-week supply of critical medications. Backup power preparation. Education on safely operating small generators or specialized battery packs for life support devices.
Preparedness is strongest when it is granular and local.
Strong community plans involve tangible actions, registries of individuals needing special assistance, a secure voluntary database that identifies where, for example, a high-dependency dialysis patient lives, allowing for proactive wellness checks. Mapping transportation routes, identifying alternate accessible evacuation routes that avoid, for example, steep hills or areas without curb cuts. Pre-disaster relationship building. This is perhaps the most critical. Building trust between responders and vulnerable groups ensures that when an alert comes, people will comply with instructions and not fear rescue personnel. Communication is the lifeline of a disaster response. Accessible communication must use multiple modalities. Plain language, avoiding complex jargon, especially when alerting people under stress. Closed captioning on all video alerts. Use of TTY and ASL interpretation on official broadcasts. Multiple formats, print, audio, video, to account for all sensory needs. Furthermore, shelters must support independence. This means ensuring accessible showers and bathrooms for hygiene, setting up quiet areas for those with sensory needs, and ensuring medical access is swift and dignified. For many people, daily function relies on a personal support network, PSN, which can include family, friends, caregivers, and medical providers. A disaster instantly disrupts these networks. A caregiver may be unable to reach a client due to blocked roads, or a pharmacy may be destroyed, cutting off a key supply line. Plans must therefore account for these disruptions. Temporary caregiver support, protocols for mobilizing emergency substitute caregivers, access to replacement supplies, a cache of backup medical supplies centrally stored, medication continuity, agreements with nearby states or pharmacies to refill prescriptions in an emergency. Every individual with functional needs requires a complete and practiced GO plan. This is their personal resilience blueprint. A complete plan includes medication list and storage plan, including dosage and doctor contact information stored in a waterproof container. Backup power, fully charged battery packs for any life support or mobility devices. Copies of medical records, essential if they are seen by an unknown doctor in an unfamiliar hospital. Pre-arranged transportation, a confirmed contact who can pick them up using an accessible vehicle. Practice evacuation steps, knowing the fastest and safest way out of the home and neighborhood. Emergency shelters and distribution centers are lifelines, but only if they are accessible. They must provide accessible entrances and pathways, wide, unobstructed routes that can accommodate wheelchairs and mobility scooters. Private medical areas, space for wound changes or private medical conversations. Quiet spaces for sensory needs, away from the main crowd and noise for those with cognitive disabilities or light sound sensitivity. Space for caregivers and medical devices. Enough room so people aren't forced to abandon equipment or their essential human support. Operational planning in the shelter is crucial for safety and health. Separate protocols for medical waste, proper disposal of needles, biohazard dressings, and other sensitive materials. Refrigeration, dedicated, reliable cold storage for items like insulin, specialized infant formula, or certain injected medications. Secure charging stations, designated, reliable outlets for charging assistive technology without the risk of theft or damage. Trained staff, personnel who can provide functional needs support, not just general intake services. Even a simple process like receiving water or food must be accessible. Distribution centers must offer physical access, not just ramps, but also wide doorways and easy-to-navigate flow. cognitive access, clear, picture-based signage, and staff who can patiently guide individuals with cognitive disabilities through the process. Communication access, staff trained to use simple sign language or pre-printed communication boards. Accessibility cannot be an afterthought. It must be the foundational design principle. To ensure everyone is reached, especially in the chaos of a disaster, we must use redundant communication systems. Text alerts for those with hearing impairment, visual signals or flashing lights for those with hearing impairment, ASL interpreted videos for the deaf community, simple language audio messages broadcast over multiple channels. The core principle here is that no single method can reach everyone, and relying on just one is a recipe for failure. Technology can be an equalizer if deployed correctly. Wireless emergency alerts, WEA, critical text-based alerts that bypass cellular network congestion. Social media broadcasts, leveraging platforms that many people, especially younger generations, use for information. Backup power for devices, ensuring public information screens, accessible computer terminals, and emergency radio systems remain operational. Accessible charging stations, public points where people can safely recharge their phones or life support batteries. The critical requirement is that technology must match user abilities and not create new barriers. Evacuation is one of the biggest barriers. Standard buses are insufficient for many vulnerable individuals. Therefore, evacuation planning requires accessible vans for small group transport, lift-equipped buses for transporting people in wheelchairs or scooters, emergency medical services, EMS, for bedridden or critical medical transport. The logistics must be pre-planned to ensure these specialized vehicles can be mobilized quickly and safely. The infrastructure itself must be resilient. Critical facilities such as hospitals, functional needs shelters, and emergency operations centers must ensure backup generators that are robustly secured above flood level, secured utility lines and fuel sources to prevent catastrophic loss of power or water, reinforced structures capable of withstanding high winds or seismic activity, designated special needs shelter areas that are immediately equipped for medical support. Effective warning systems must be proactive and specific. Track at-risk individuals using the voluntary registries to know who needs specific targeted outreach. Confirm alerts were received, not just sending a broadcast, but employing a system to check that the message was received and understood by key at-risk groups. Provide wellness checks, prioritizing calls or visits to individuals with high dependencies following an event. Prioritize urgent medical needs, flagging critical individuals for immediate evacuation or medical delivery. Tactile and audible signage. A critical but often overlooked detail is wayfinding for people with visual or cognitive impairments. Shelters and evacuation routes must include braille signs in raised lettering for navigation, audible beacons that provide location and direction information, clear, consistent placement of universally recognized symbols, evacuation assistance, dignity and safety. The act of physically moving a person from danger requires precision and respect. Evacuations must ensure safe lifting and transfer techniques, proper training in how to move someone who cannot bear weight to prevent injury to both the person and the responder. Use of proper equipment, utilizing specialized transfer chairs or sleds, not makeshift solutions. Maintaining dignity and physical safety throughout the entire process. Conclusion. We conclude where we began. Inclusive emergency planning is not a negotiable option. It is a legal requirement under federal law, a public health priority to reduce morbidity and mortality, a moral commitment to the value of every life in the community. Protecting vulnerable populations demands equity, collaboration, and respect for diverse needs. When planning is done right, it doesn't just improve outcomes for a few, it enhances the entire community's resilience.